Thank you for joining today's Congressional briefing. I'm Bruce Lesley, President of First Focus on Children. We're pleased you are here with us today as we hear from experts on children's health care and the COVID-19 vaccine. We first want to thank our congressional sponsors for today's briefing, Senator Sherrod Brown and Congresswoman Kim Schreier. Senator Brown has been named by us as champion for children for 9 consecutive years. He's one of the leading champions for children in the U.S. Senate. Congresswoman Schreier is an outstanding supporter of children in the House of Representatives and a leading expert on these matters as the only pediatrician serving in the Congress. Congresswoman Schreier, thank you so much, and to Senator Brown as well, for convening us today for this important conversation.
Thank you so much for coming to this really important briefing today in conjunction with First Focus on Children on the important issue of children and the COVID-19 vaccine. As a pediatrician, I am so thrilled that this vaccine is available for children now 5 and up. My son Sam, now 13 years old, got vaccinated as soon as he was eligible, and that made our summer normal. He was able to go to summer camp, and I want parents of all children and children 5 and up to now have as close to normal a life as possible. I am so thankful to the scientists who developed these vaccines, and now we have one that is safe and effective and eligible for children to take. This will keep them healthy, it will keep their community safe, and it will keep them safely in school. I was so happy to see the Biden administration put a lot of thought into how to get the vaccines into arms. And so they made it so that you could get vaccines at school-based clinics, at pharmacies, at children's hospitals, and even at community health centers. I was also so happy to see that there was a concerted effort to get the vaccines to pediatricians' offices, because these are conversations we have every day. I spent 20 years helping to reassure nervous parents about routine childhood vaccines. And pediatricians can do the same thing for children and families regarding the COVID vaccine. So I'm glad that they're engaging providers early. I'm so glad that they've given this rollout a ton of thought. I was able to engage with families and parents at a school-based clinic just last week and even give some shots myself. And so I just want to thank you and thank First Focus on Children for bringing us together to have this conversation about the COVID vaccine and our children.
Thank you, Congresswoman Schreier, and thank you for your comments and for your perspective and expertise on this topic as a pediatrician and for your leadership in Congress on these issues. We'd also like to thank the Robert Wood Johnson Foundation, the David and Lucille Packard Foundation, and the Annie Casey Foundation for the generous support to make this briefing and much of our work possible. After our speakers are done, we'll devote the rest of our time to Q&A. Please drop your questions for our speakers into the chat while they speak, and we'll do our best to answer your questions during the Q&A portion of our webinar. So I want to start off and do a real quick summary and really get to the panelists because they're the experts in this. A false narrative took hold early in the COVID-19 pandemic that children aren't affected by this virus. This couldn't be further from the truth. Children are suffering immeasurably under the COVID-19 crisis, and these impacts have been felt disproportionately by children of color. Nearly every aspect of the lives of children have been upended, from school and childcare closures, dramatic increases in mental health care needs, the loss of caregivers, more children living in poverty, and increasing numbers of children going hungry. Some of the things I just want to lay out for you all is some of the statistics. I won't go through all of these, but I just want to point out that a recent study found that 175,000 children have lost a primary caregiver since the beginning of the COVID-19 pandemic. So that's a critical point. With respect to racial disparities, these are some of the numbers and indicate that Hispanic, Black, and American Indian and Alaska Native children are more likely to be negatively impacted by infected and to die from the COVID. And also, I would point out that they're disproportionately their caregivers they were disproportionately affected by that as well. Next slide. We wrote a letter to the administration early in the pandemic asking them to create a plan for all children to be vaccinated. This plan included making vaccines available at a variety of facilities that were child-centered places, like child care facilities, schools, community health centers, recreation centers, youth sports venues, and other places where children spend their time. This rollout needs to be very different than that happened for adults. We need to engage doctors, nurses, priests, religious leaders, school teachers, principals, anyone else trusted by parents, grandparents, and caregivers, including community health workers in neighborhoods, community health centers. We also do need to make sure that we do outreach to immigrant communities and to make sure that we have translation materials that address all the different languages spoken in our country. We also need to make sure that we adequately fund these efforts, among other strategies. So with that, I want to introduce our speakers today and get to them. And so first, we are pleased to see to see these outstanding experts here with us today. So I want to start with Dr. Rhea Boyd, and she's a pediatrician, health advocate, and scholar, someone who I have a great admiration for. She writes and teaches on the relationship between structural racism, inequity, and health. She co-developed The Conversation Between Us About Us, a national campaign to bring credible information for the COVID vaccines directly to Black, Latino, and Spanish-speaking communities. She holds a BA in Africana Studies and Health from the University of Notre Dame and an MD from Vanderbilt University School of Medicine. She completed her pediatric residency at the University of California, San Francisco. In 2017, she graduated from the Commonwealth Fund Mongan Minority Health Policy Fellowship at Harvard University School of Public Health, earning an MPH. So she's, quite lots of letters after your name, Dr. Boyd. So really appreciate you being here today with us. And she will lead off, and then we will turn to Dr. Jessica Calarco. She's an associate professor of sociology at Indiana University and a member of the board of directors of the Council on Contemporary Families. Dr. Calarco is an expert on family life and education, and her research focuses on parental decision-making. Dr. Calarco has authored 2 books and holds a PhD in sociology from the University of Pennsylvania. Thank you for being with us. And also Dr. Michelle Fiscus. She's a board-certified pediatrician who's currently working with the National Academy for State Health Policy. She practiced general pediatrics in Franklin, Tennessee for 17 years before joining the Tennessee Department of Health in 2016. She most recently served as medical director of the Tennessee Vaccine Preventable Diseases and Immunization Program. Dr. Fiscus completed her undergraduate medical school and residency at Indiana University and an associate clinical professor in the Department of Pediatrics at the Monroe Carroll Jr. Children's Hospital at Vanderbilt. She's past president of the Tennessee chapter of the American Academy of Pediatrics and now serves on the National Board of Directors as District 4 Chair. And she's also someone all 3 of you I have great admiration for. So I'm really pleased to have you here with us today. So let's get started. We'll turn it over to Dr. Boyd. Thank you so much, and we look forward to your comments.
Hey everybody, thank you again for that beautiful introduction. It's an honor to be a part of this panel. I'm just gonna minimize this and share these slides. So what I'm gonna be talking about is the ways that growing inequality in our country has shaped the distribution of the pandemic. It'll briefly cover some of the racial inequities that Bruce began with, but for folks who have more questions about what we talk about, I'd be happy to get into more specifics. But predominantly what I'm going to do is challenge this notion that hesitancy has really driven who is most affected by the pandemic and who has greatest access to the COVID vaccines, and instead put in front of us some pretty compelling data about pre-existing access barriers to healthcare that have also shaped the distribution of who has received the COVID vaccine. So first, I just wanted to look across the country at where we see current outbreaks of COVID, and we can see areas in the Northeast and in the Southwest that right now have a predominance of new cases of COVID. This is data taken from New York Times that gets updated daily, and this is data as of yesterday. But now I want us to go back in time to early September. This is a time when we saw the peak of the Delta surge, or the surge from the most recent, more contagious strain of COVID. And what we saw during that surge, as we saw during the previous winter surge, is a concentration of COVID cases in the US Southeast. We similarly, during that peak of the COVID surge, saw a concentration of hospitalizations for COVID in the Southeast. When we looked back then, we saw that the Southeast was also an area that was disproportionately less likely to be vaccinated. So this again is data from data visualizations from the New York Times that covers areas in the country where there are residents who are fully vaccinated. And so anywhere that's lighter on this map are areas that have lower percentages of the population who are fully vaccinated. And you can see the lighter area really concentrating here in the Southeast. If we look at just yesterday, we see that that trend hasn't changed. From the surge in Delta to now, we still see areas of the Southeast remain areas that are vulnerable to COVID surges because of the lower vaccination rates disproportionately in those areas. When we think about what populations that is then affecting, we have to confront the fact that most Black or African Americans in this country live in the US Southeast. This is data from Kaiser Family Foundation from 2019, and it's a heat map that shows population density. And so anywhere where you see a darker area on the map is areas where you see a predominance of Black or African American populations. And so here we see those darker areas concentrating in the Southeast. Similarly, if we look at the population distribution of Latinx or Hispanic populations, we see a predominance across the US Southwest and the Southeast in states like Florida. If we think about what that means for the national vaccination effort, we see that both Black and Hispanic or Latinx populations are among the least vaccinated groups in the country. I put a red box here. This is data from the CDC's data tracker. I'll note that this data has a relatively high level of data missingness, which means there are many states who are not reporting their COVID vaccination rates by race, sex, and age to the CDC at the national level. But what we can see is that the inequities that we were concerned may exist continue to persist as of November 16th, the most recent day for which the CDC has publicly available data, particularly for Black, Hispanic, and Latinx populations. When we look across age groups, we see that individuals who are age 15 and below have the lowest rates of COVID vaccination. We know this is in part because individuals aged 12 to 15 were just recently authorized to receive a COVID vaccine as of May, and so they haven't had the same time as other age groups to get vaccinated. But we also see lower levels of vaccine uptake in these groups and a plateauing of the daily vaccination rates, which concerns us that caregivers may not be choosing to vaccinate their 12 to 17-year-old at the same rate that we saw, for example, the elderly get vaccinated. Whereas you can see for populations 75 years and above, they have over 80% who are fully vaccinated. And then obviously, just since the 5 to 11 rollout, individuals in our country who are age 5 to 11 have the lowest vaccination rates, but data just from today suggests that almost 10% or 2.6 million out of the 28 million kids who are age 5 to 11 have received their first dose of the COVID vaccine, which is reassuring, but as we know, insufficient to fully protect that population. And so to Bruce's point about how kids have been affected by the pandemic, we as pediatricians know that kids have been affected all along. So this is data from the American Academy of Pediatrics that looks by each week in the pandemic. And so the most recent week for which we have data is last week that ended in November 11th. But what you can see here are each of these peaks represent a surge in COVID. And the most recent peaks to the right on this curve represent the Delta surge. What we see is that adult cases predominate and that they're more common than child cases, sure, but that every time you see a surge for adults, we have seen a similar corresponding surge for children. And as Bruce presented some of the bereavement data in caregiver loss as a result of the pandemic, every one of the light blue bars that represents adult cases also potentially represents the loss of a primary or secondary caregiver for a child, which we know as pediatricians affects not only the daily care needs of a child and their immediate well-being, but also their future health and well-being, and puts them at greater risk for chronic illness. If we then look at data disaggregated by race and age, we see that across the country, we do not have very many states who are reporting data on kids and racial inequities in COVID vaccination rates. So for the states for which we do have data, Kaiser Family Foundation pulled together a summary back in September. And what you can see is that for nearly every state that's been reporting that data, we see persisting inequities, particularly for Black and in some areas also for Hispanic or Latinx children, who are the least likely to be vaccinated among kids aged 12 and up. This is 12 and up because this data was in September before the recent authorization for 5 to 11. So when we think back to that distribution of disease we saw across the country, where there's a predominance of COVID infection in the South, particularly during surges of COVID infection, we have to think about what might be contributing to that. And one of the factors that we can't look away from is that insurance access is not evenly spread throughout the country. In fact, this data from Kaiser Family Foundation in January of this year told us that 97% of adults who live in the coverage gap live in the US South. 97%, nearly everyone, right? So what's the coverage gap? The coverage gap means you're an adult whose income is too high to qualify for state-sponsored insurance like Medicaid, but too low to qualify for tax subsidies to enter the marketplace. And so the states that are most at risk to have adults and their households who fall in the coverage gaps are states that fail to expand Medicaid, which is why when you look to the left, you can see the breakdown of the coverage gap predominates from states that have not expanded Medicaid. This matters because what we see is that when we ask folks, and this is data from Kaiser Family Foundation again, when we ask folks where they want to get their COVID vaccine, many people want to go to places that you are most familiar with and you have the greatest access to if you have health insurance. So what they found is most people want to go to their own doctor's office, which is completely understandable. People want to go to hospitals near them or community health clinics or even pharmacies. But again, these are areas that you know how to navigate if you've navigated it before because you have the means to do so. We also see, particularly for parents and caregivers, that the place that they want to get information about the COVID vaccines are also places that you need health insurance to access reliably. So we know that most kids in this country are covered by health insurance, but we also know that if parents aren't covered, they're less likely to seek healthcare services for their child, even if their child has insurance. And so it matters when parents say they want to hear this information from their child's pediatrician, that we know that there are parents who don't have insurance who might not be able to access their child's pediatrician. And there are also parents who want to hear this information directly from their insurance company. And again, inequities in insurance access then shapes who has the information they need to make this choice reliably. And so back in August, before authorization of the COVID vaccines for 12-year-olds, Kaiser Family Foundation looked at which parents were vaccinated as a potential way to project which parents might be interested in vaccinating their kids. And what emerged was truly what we have been describing as this pandemic of the unequal, that particularly young parents aged 18 to 39 were less likely to be vaccinated, low-income parents whose income was less than $40,000, Black parents, as we've covered, which is an inequity that's really persisted in vaccine access, and Republican parents were less likely to be vaccinated, which raised concerns back in August that these groups might also have children who were less likely to have good, reliable access to the COVID vaccines. When we specifically asked, when Kaiser Family Foundation specifically asked Black and Latinx parents about their barriers to vaccination, they highlighted some access barriers that policymakers need to take into account. First, paid sick leave is paramount for parents to be able to take time away from work to either take their kid to get vaccinated or to be with their child should their child have any of the common side effects or even a more rare side effect that requires prolonged care. Parents also worried about not being able to go to a trusted site. Again, if you don't have health insurance and you're not familiar with a provider and you don't have that longitudinal relationship, they worried that they wouldn't be able to get the vaccine in that setting in which they feel most comfortable. Parents expressed concerns about out-of-pocket costs to get their vaccine for the kids and the difficulty of travel. I want to say a brief word on out-of-pocket costs because there was a lot of media attention around the fact that the vaccines are free and that people may not know that. But what we miss when people say out-of-pocket costs is that obtaining medical care in this country is never cost neutral. The other out-of-pocket costs, in addition to the actual medical procedure or service that you're receiving, are the costs it takes to arrive and return from that medical procedure or service, right? You need gas in your tank, you need bus fare, you need a train ticket. Perhaps you need childcare so that you can go with the children who are eligible, but the children who are not age eligible might be better left under the care of another loving caregiver. And so if you don't have the resources for those things, you have to expend resources then to get a vaccine. And even if that vaccine is free, it can place it just out of certain families' reach. And so when it comes to paid time off, for example, parents of 12 to 17-year-olds early on said free transportation to the site, which the Biden administration worked with ride sharing services to try to provide for folks, can really help them make this choice to get their child vaccinated, or having medical providers come offer vaccination for them and their children right at their work site. For places that have workplace mandates, co-locating the vaccine access at the work site can be a really useful way to help people adhere to those mandates. We also saw that higher income parents were more likely to have the information they need about the COVID vaccine given to them by their child's school, because we know that school districts are also racially segregated in this country, and lower income school districts are also school districts that are predominantly Black or Latinx, that means that those families are less likely to have this critical information as they make this choice, which also makes them more susceptible to the rampant misinformation and disinformation campaigns that dissuade families from choosing vaccination. And so my take home is that our nation's unvaccinated are not just anti-vaxxers. They are also folks who our healthcare system has chronically underserved, and those populations' children. And so we have to come to confront the real and perceived barriers to access so that vaccination is a possibility. One predominant way to do that is family vaccination, which means anytime a child shows up for any type of service, everyone in their family needs to be offered vaccination as well. Whether you go to the ER, whether you're going to a well child check, whether you're going to your after school program, or you're coming to school. We need to make sure that where families go are places where they can receive the COVID vaccine, not just for the individual who's being served there, but for the entire family. Community-based sites were an early place that were very successful to do that for adults in the rollout, and they may continue to be important for kids as well. We also need to address making vaccination cost neutral, which is an additional step to making the vaccine itself free. Family vaccination is also well supported by the data. There was just a study from JAMA, the Journal of the American Medical Association, back last month that looked at over 800,000 families and found that as the number of vaccinated members of a household increase, the incidence or case rate of COVID in that household decreases by as much as 97%. It's a little dramatic to look at, so I just briefly want to show you. So in the top left here at A, that black line going up is the rate of COVID when you don't have anybody in your household vaccinated. And each subsequent box shows that curve bend towards zero as another member of the family gets vaccinated. So family vaccination doesn't just make sense in terms of policy, it also makes sense in terms of public health. It is the best way to protect households, which is often where people are exposed to COVID. We also need to make sure that families have access to credible information about the COVID vaccines, which has been the lion's share of our work with the Kaiser Family Foundation, Black Coalition Against COVID, Unidos US, and the American Academy of Pediatrics. Our website is www.betweenusaboutus.org. We feature Black, Latinx, Hispanic, and Spanish-speaking providers, so doctors, nurses, promotoras, and clinical scientists sharing the science about the COVID vaccines. Our campaign has been really successful online and even more successful in some of our groundwork to go door to door in rural parts of the country to make sure people have access to this information even when they don't have access to the internet. If you are interested in sharing any of our content with your constituents, our website is just www.betweenusaboutus.org. All of the information is free to use and share, and you can feel free to reach out to me if you would like more access to it. But more generally speaking, a long-term policy agenda that we all need to take seriously are the access concerns that underlie the uneven distribution of the COVID pandemic that we now need to get about addressing in preparation for future pandemics that are almost certainly coming. So we need to talk about what it means to remove insurance as a barrier to access to care in this country. We need to talk about what it means to provide every child and family childcare, to provide every worker in this country paid sick leave, which we just had an opportunity to do, and we hope that opportunity returns. We need to talk about what it means to provide credible information about health to everybody, which for some things will mean removing paywalls from journals so that everyone can access this public health information, and making broader investments in the social safety net. And lastly, I just want to say that we have been able to see since early in the vaccine rollout some shifts in the inequities and narrowing actually of racial inequities in access to the vaccine. So I put a blue box here around Black adults. So the CDC data I showed early on around vaccine access had a level of data missingness. But when you poll populations, as Kaiser did here, by racial and ethnic group, we see relatively high levels of vaccination across racial and ethnic groups, and that racial and ethnic groups report more than 70% have received at least one dose of a COVID vaccine, which is incredible, and I truly attribute to the work of workers in these communities and community members who have really done a ton to make sure our communities are protected. But now there are new groups who are at risk that we need new strategies for, and I put a star here. White evangelical Christians, folks who report voting Republican, and folks who live in rural America have at least a quarter to a third of their population who have said, when polled, they definitely do not intend to get vaccinated, which again reflects likely barriers to credible information about the COVID vaccines. And so we also have to talk about what it means to confront the anti-science movement that has been taking place in this country, that has been undermining folks' confidence in the vaccines, what it means to challenge structural racism and the way it shapes who has access to healthcare in general in this country, and what it means to make our country more just at baseline. So thank you again so much for having me.
Thank you, Dr. Boyd. That was a great look at all the various issues on vaccine access and strategies to overcome those barriers. We really appreciate it. And Dr. Calarco, I want to turn it to you now. And we look forward to hearing about your research with families.
Thank you so much, Bruce, and thank you to Dr. Boyd. And I hope to pick up on where Dr. Boyd left off here. And speaking about the research that my team and I have been doing on families and their decision-making, we started back in 2018 and followed a number of 250 families through the pandemic and their decision-making, interviewing them and surveying them about the choices that they've made. And specifically, our research focuses on families in Indiana, which is a state that represents those starred groups that Dr. Boyd pointed to on one of her previous slides. White Americans, Republican-leaning Americans, and those who identify as evangelical Christians. And the first story that I'll share with you today, if we could advance to the next slide, is a mom that I'll call April, who I interviewed recently as part of our pandemic parenting study. April, who's a full-time homemaker, is white and has a college degree and identifies as Republican. Her husband, Mateo, is Latino, has a master's degree, and is a full-time youth pastor at an evangelical Christian church. And he earns about $30,000 a year, which qualifies their family for Medicaid. Before the pandemic, April and her husband got all the normal vaccines for their kids. And when it comes to the COVID vaccine, though, April and Mateo aren't so sure. April said, quote, "I just feel like there's almost no incentive at all to give them the vaccine. Even if there was like no risk to it, it just seems like why would we even get it for them? Even if they were to get COVID, they would be able to heal pretty quick, and it's unlikely that they would spread it to others." And so I asked April, what if anything would change her mind about the vaccine? And she said, quote, "If the COVID death rate for children was significant, I would be begging to vaccinate my children, but statistically that's not the case." And if we can go to the next slide, April and Mateo unfortunately aren't alone in choosing not to vaccinate their kids against COVID. A recent poll from the Kaiser Family Foundation found that only about a third of parents with children ages 5 to 11 plan to vaccinate their kids right away. And among parents with children under 5, it's less than a quarter who plan to get the vaccine as soon as possible for their children. Meanwhile, even among children who are currently eligible, those ages 12 to 17, vaccination rates, as Dr. Boyd mentioned, are far lower than those among older adults. And if we can go to the next slide, those numbers contrast sharply with uptake rates for most other vaccines for children. More than 90% of kids in the US are fully vaccinated against polio, against measles, mumps, rubella, hepatitis B, chickenpox. More than 80% are up to date on their Tdap shots. And so that raises an important question about what's different about the COVID vaccine. And to answer that question, I draw on data from a study of 250 families whose vaccine decisions we've been following since 2018. We started with these 250 moms of young children from varied backgrounds who were recruited through health clinics here in Indiana. About 30% of those families have at least one parent of color, about 30% are on Medicaid, more than a third receive WIC or food stamps, and then it's about evenly divided across political groups, about a third Democrats, a third Independents, and a third Republicans. And so every 6 months since the start of the project, we've been surveying and interviewing those moms and their partners about the kinds of decisions that they're making for their children, including decisions about vaccines. And when the pandemic hit, we expanded the study to also include questions about families' pandemic decision-making, including vaccines. And we've now conducted 3 waves of pandemic surveys and interviews, with the 3rd wave ongoing right now. So with these data in mind, let's return to our central question of what's different about the COVID-19 vaccine. And what I find here is that there hasn't been as much urgency around COVID-19 vaccines for children, at least in part because public health and media messaging, especially early in the pandemic, created a sense of moral calm around kids and COVID. And this is essentially the opposite of a moral panic. It's a situation where we might expect to see widespread concern about some potentially harmful phenomenon like COVID, but get the absence of fear instead. And during the pandemic, and particularly early on, public health experts and media messages were often reassuring parents that kids, especially quote unquote healthy kids, were at low risk of contracting and spreading and getting seriously ill from COVID. And that's essentially what some of these headlines and news stories kind of point to from outlets like CNN and NPR. And what we found in our research was that these kinds of messages led many families to believe that COVID isn't a serious threat to their kids. We can go to the next slide. So one Asian American mom, for example, told me she's a mental health counselor, but she's not planning to vaccinate her kids. And she said the data just show that they're not very high risk at all. And essentially seeing kids as low risk for COVID led parents to believe that COVID vaccines were just unnecessary for their kids, or many parents, certainly not across the board, even if their kids had previously gotten all their vaccines, and even if the parents in some cases had gotten COVID vaccines for themselves. Consider, for example, a couple that I'll call Laura and Tony. They're both white and they both have college degrees. Laura's a self-employed marketing consultant and Tony's in the military. Together, they earn about $55,000 a year, and they both identify as independents. They have a toddler and 2 kids in elementary school who've previously gotten all their vaccines. Even Laura and Tony themselves are also fully vaccinated against COVID, but they aren't planning to vaccinate their kids. As Laura explained, she said, quote, "If it was something like smallpox, I would feel a much greater level of concern than I do in this situation. I'm not sure I believe the benefits of the vaccine for children outweigh the risks and the unknowns." And so essentially, if a parent perceives the benefit of the vaccine to be 0, then any risks associated with the vaccine automatically outweigh the benefits. And that means that the moral calm around kids and COVID is essentially leading parents to focus on the potential risks of the vaccine rather than on the potential benefits for individuals and for society as a whole. And to that end, consider Patricia, who's a low-income Black single mom who doesn't have a college degree and works in customer service. She earns about $12,000 a year, which qualifies her and her kids for Medicaid and for WIC. She has a newborn, a toddler, and 2 kids in elementary school. She identifies as a Democrat, and she actually just very recently got the vaccine for herself. Speaking to Dr. Boyd's mention on sort of the uptick recently in Black Americans getting vaccinated just a couple of weeks ago. But she's only planning to get her kids vaccinated against COVID if it's required for school. And so she told me, for example, she's nervous that one of her kids might have a bad reaction to the vaccine and end up in the hospital. She said, quote, "I would feel bad if I just did that to my kid. So I'm going to wait and see, because I know that we've been tested for COVID and we're negative. We wear our masks, we're doing everything else, and we've been okay so far." So essentially, parents are using a very individualized risk-benefit model to decide whether or not to vaccinate themselves and their kids against COVID. But the problem with that kind of individualized risk model is that vaccines aren't just designed to protect individuals from getting very sick. They're designed to help keep people from spreading it to others, and particularly others who might be at higher risk than themselves. And that's why high rates of vaccination, some estimates say at least 70% of the total population here in the US, will be necessary to stop the spread of COVID-19 and help families get back to more of their familiar routines. At the same time, though, it's important to note that despite what many parents believe, COVID-19, as we heard Bruce mention at the beginning, and Dr. Boyd alluded to this as well, that the COVID-19 does pose a serious threat to children, including kids who've never been diagnosed with any pre-existing conditions. We heard figures around the 6.5 million kids in the US having contracted COVID, thousands having been hospitalized, more than 600 having died of COVID-19, and certainly kids also can play a role in spreading it to others, including many in their families. And we heard the statistics, I think it's even more now than the 140,000 I have here in terms of those who've lost caregivers during the pandemic. And as we heard, the unequal impact of these kinds of deaths and illnesses and the role that those have for families as well. Unfortunately, though, the new information about COVID risks, particularly for children, has not always reached the parents who need it. And that's in part because many of the families that we've talked to have stopped actively following the news around COVID-19. Many of the parents that we talk to tell us that they're overwhelmed and frustrated by all the back and forth information about COVID. They're tired of how polarized the pandemic has become. And so as one mom told me, she said, I'm just putting my head in the sand instead, and essentially just not following the news anymore. So what do we do about this? To get at that question, my team and I asked parents, what would it take for them to get the vaccine for their children? And parents' answers to that question point to two key strategies for increasing vaccine uptake. First, working with trusted community leaders to help parents recognize the risks of not vaccinating their children, including the risks that COVID poses to individual children, and also the role that kids can play in spreading the disease to other people. Essentially, if we want to connect with those parents who've put their heads in the sand, news-wise, we need to work with people they trust in their communities, including religious leaders, pediatricians, and even influencers on social media, because oftentimes if parents have stopped engaging with official news or stopped going to the CDC website, they're still checking Facebook every day. And so that leaves them more susceptible to disinformation that they happen to see scroll past instead. Now, if those trusted community leaders can help parents to recognize the seriousness of COVID and kids' role in spreading the virus, more parents may come to perceive the vaccine as necessary for their kids. And then second, I would argue that we can also consider taking the burden of choice off of parents by considering things like vaccine requirements for children. And this might seem counterintuitive, but the problem with choice is that choice comes with responsibility. And if parents get to choose the vaccines for their kids or have to choose the vaccine for their kids, and if kids do experience side effects, then parents, like we heard with Patricia, blame themselves for subjecting their kids to those kinds of consequences, even if not getting the vaccine would have ultimately put their kids at risk for greater harm. When vaccines are required, on the other hand, parents don't feel as guilty about any side effects that their children do experience because they blame the vaccine then, and they don't blame themselves as much for making that choice. So thank you so much for your time. My contact information is on this last slide. Please feel free to reach out if you have additional questions about the research that we're conducting. And there's also been some links in the slide here as well. Thank you.
Thank you, Dr. Calarco. It's so helpful to learn about your research into parental decision-making. And now I want to turn it over to Dr. Fiscus. We're excited to hear about what's happening on the ground in states as we work to get more children vaccinated. So thank you, Dr. Fiscus.
Hi, good afternoon. It's wonderful to be with all of you and really wonderful to listen to Dr. Calarco and Dr. Boyd. And I hope to also build on that a little bit. So, one of the things that we've been looking at is legislation that has come forward in states over the course of the pandemic. If you want to go to my first slide there. And so when I did just a little cursory review of that, over 48 states and territories, there were 1,532 bills that were introduced specifically related to COVID-19 and public health, or COVID-19 vaccines, or legislative oversight of executive authority related to COVID-19. So this has obviously been a huge issue within state legislators. And there have been some special sessions that have happened over the course of the summer where even outside of regular session, laws have been passed. Some of those are helpful in working to get people vaccinated and reducing inequities, and in some cases they work against that. Of those 1,500 or so bills that have been passed, a little over 200 of them have actually been passed in their respective states, so about 1 in 7. And some of them facilitate vaccination. So good things in that we have a lot more vaccinators than what we did at the start of the pandemic, because states have said that, okay, dentists and ophthalmologists and optometrists and veterinarians in some cases can go and vaccinate people, which is good. You know, if you can have someone who's there in a dental chair getting their refraction done and offer them a COVID vaccine at the same time, that increases some access. It's very important to be protecting our public health workforce, who is very much overworked and stretched very thinly. And so some states have passed laws against harassment at vaccination sites, both to protect the people who are there getting vaccinated, but also to protect the vaccinators that are out there trying to do that work. Mandatory reporting for state registries of vaccinations to make sure that we do get that data around race and ethnicity, and make sure that we know who has been vaccinated and who has not, can be really helpful in making sure that we know how to target areas that have lower vaccination rates. And then, just as Dr. Calarco mentioned, school mandates or school requirements, which we prefer to say, it can be very important in getting kids to get vaccinated. You know, we know that states that have few abilities to opt out of vaccinations, for example, the state of Mississippi, that only allows medical exemptions to school required vaccinations, have some of the highest vaccination rates among children in the country. On the flip side of that, the state of Mississippi does not require HPV vaccination for students to enter school, and they have the lowest vaccination rate in the country. So school mandates and school requirements really do make a difference in some states and territories. Puerto Rico, for one, have enacted those school requirements, which will be very important. But then there's been some legislation that can actually work to impede some of the access. For example, there's a handful of states that have mature minor doctrines that allow older teenagers who are determined to be mature by their medical providers to consent for their own health care, including vaccinations. And some states have now rolled back the ability to do that specifically for COVID-19 vaccine. That reduces access in that we have kids that have working parents who may not be able to take them to get vaccinated, who may have other barriers to getting vaccinated, or mature teens who may have parents that don't want them to get vaccinated but want to make that decision for themselves. And so some of these laws now are taking that decision-making authority away. And then several states that have put bans on school required COVID-19 vaccines and also future vaccines. So in one state this summer, they actually not only placed a ban on COVID-19 vaccines, but no other vaccines, COVID or not, can be introduced as a school requirement. And so that takes then legislation to undo that when things get dire, and that's not something that can necessarily be done quickly. The other thing it can do is disincentivize schools from cooperating in the process and helping us to get vaccinated in schools where children are. And for a lot of children, it's going to be incredibly important that they be able to access these vaccines at their school when they're there during the day. And in states that that then have bans on those types of mandates, some of those school districts may be a little more hesitant to have those kinds of school-located vaccination clinics. Next, please. So one of the things that we can do is use tools that are out there readily and freely available to help us find people who are willing to get vaccinated. You know, as we've already heard from Dr. Boyd and Dr. Calarco, about a third or so of parents are saying that they're not going to get their children vaccinated, but there's still a majority of people who are at least willing to engage in the discussion about that. And if they're not first in line, they're at least willing to have the talk. So this is an example, a couple of screenshots that I took from vaccineplanner.org, which is a wonderful tool that's been put out by Ariadne Labs and Boston Children's Hospital. It is free, and you can go on and pull up your state. And what the colors mean is the tan areas are areas that are considered vaccine deserts. So this means that there is not a vaccine provider for COVID-19 vaccine within a 15-minute drive of people who live in those tan areas. And the little red circles are providers that are not participating in the COVID-19 vaccination program right now, but who could. And you can see that many of those providers are sitting right smack in the middle of those vaccine deserts. And so if we can work to encourage those providers to get on board with the COVID-19 vaccine program, then they can start to vaccinate people who are in those areas. And then the purple areas that you see are areas where people have said that they've not yet gotten vaccinated, but they're willing to do so. And so again, if we don't have providers in areas where people are willing to get vaccinated, then, and it's not necessarily the top thing on their list to go get done, and there's a considerable distance to find a vaccination site, then those people are sitting there still at risk, but actually willing to get vaccinated. And that's on the order of thousands of people in these states that are there and willing. And so using something like this tool at vaccineplanner.org can help us go in and locate zip codes and neighborhoods and areas where we can take mobile vaccination units and buses and put up vaccination sites in faith-based centers or community centers or Boys and Girls Clubs or YMCAs to help get people vaccinated who are in those areas who may not otherwise access that. So I would highly encourage you to go and look at tools like this that are readily available for you, that have wonderful data that's improving all the time. This site even now can help us identify areas that don't have pediatric vaccine providers specifically, so that we can try to locate pockets of children who need to be vaccinated, who may not have ready access to do that. So I will stop with that. My contact information is on the next slide. Big shout out to the Virginia Department of Health for having these wonderful graphics with kids in superhero costumes who are ready to get vaccinated. And I'm happy to take any questions that come up. Thanks.
Thank you, Dr. Fiscus. It sounds like there are some places doing some really great work to reach out to kids, and yet there's so much more to be done. I was taking notes while you were all talking and you know, identified a number of barriers that you all talked about, and I think this is an important conversation because I think the complexity of that is important to address. So as you all talked about, we've had some conversation around access to care in various ways, even issues around the social safety net, right? So childcare and family medical leave kinds of issues, both information and disinformation problems. Then there's some, you know, some who have hesitancy issues, and then certainly issues around state and local laws. Have I missed? So my question to you all is: have I missed some of the barriers that we need to really think through? And then also, what can federal and state policymakers do to kind of help address some of these barriers? And then also, what can state and local advocates do? So sorry for the three-part question, but so let's start with you, Dr. Boyd, and then we'll go down the panel. Thank you.
Yes, it is a complex question. I'll be brief. I think what I was trying to illustrate in my presentation that I'll just reiterate here today is that the barriers that are going to come up when we have public health emergencies like the COVID-19 pandemic are pre-existing, right? Even in the last slide that Dr. Fiscus showed about areas where we know that there are healthcare deserts, where people don't have reliable access to these services, means those areas are outside of the reach of the systems that we have created to serve everybody. And so then when we have an initiative like a vaccine rollout that's so ambitious that we're trying to have every single household and individual right now 5 and up get a medical service, we are then impaired by the pre-existing barriers that we've created. So that's why some of the solutions I tried to land on are long-term policy solutions that we should consider urgent. Thinking about universal access to healthcare is an urgent policy solution for future health crises. It will ensure that everyone has access to whatever service we're trying to roll out, that they are familiar with the process to access that service because they've received it in the past, they know where to go, they know the number to call, they know how to get there, etc. And that the other social supports around that are really critical, that just health care services enough are insufficient to make sure people can actually receive that service, that we have to make sure that paid sick leave is not something that's contingent upon how wealthy the position that you occupy is, but is instead just a right of every laborer in this country, as is free childcare for every caregiver, not just those who have the means to provide it.
Dr. Calarco, I'm sorry.
Oh, no, you're fine. And thank you. And certainly I'm happy to build on what Dr. Boyd just shared and pointing to this need for a stronger social safety net. I think it not only helps to ensure access and to make sure that families are in a position to be able to take advantage of the healthcare that they can access once they do have that access. But I think we also have to think about how our lack of a social safety net and our culture of individualism in the US go hand in hand, and how that emphasis, how not having an adequate healthcare social safety net, not having adequate financial support and logistical support for families puts more pressure on families, and particularly on mothers, to protect their kids and to feel like they have to do all that work themselves. And when we put that much pressure on mothers and on families more generally, it also makes mothers more wary of potential threats to their children's health and makes them more susceptible to misinformation and disinformation about risks of vaccines. And so I think we also have to think about how an investment in a stronger social safety net with things like universal health care and more adequate and expanded, closing that gap in terms of who has access to care, who has access to the financial support that they need, can help to reduce the pressure on families and make families feel more supported by their communities, and make mothers feel less judged if their children do end up having health problems or do end up experiencing the extremely rare side effects, so that they don't have to worry as much about how that will be seen as a reflection of their choices in a very individualistic system. Thanks.
Dr. Fiscus.
Yeah, and I'll add to all of that I'm very concerned about the public health system. This is a system that has been historically underfunded, underappreciated, overworked, and understaffed. And in a time like this, when money is raining down from everywhere, our public health system is probably going to be less prepared for the next pandemic than we are for this one, because we've had people leaving the profession in droves because they have been abused and mistreated and overworked, and frankly doing a lot of things that are outside of what they were supposed to be doing on a day-to-day basis. And so a lot of public health has suffered as a result of this. The sexually transmitted infections programs, the HIV programs, the tobacco and maternal child health programs, all of these people in public health were pulled to COVID response. And so everyone is behind. And so having support both federally and from the state level for public health to do the work that public health needs to do, to work for the good of the people, to stop the spread of diseases. When you think about, if you go into a dirty restaurant, the first thing that you want to do is go report that to your state Department of Health, because that they'll come in and they'll fix the situation and make it so that it's a place where it's safe to eat. These are the same folks that are trying to protect people from COVID and from every other kind of transmissible disease that they work to prevent. So I can't overemphasize the need to continue to provide support both financially and administratively and legislatively to the public health infrastructure.
I think that's an outstanding point of that. We need to constantly recognize the frontline workers in this pandemic, and so we know to some extent and still need to do more to support our the people who are working in our hospitals and our doctors and physicians. But I think you're right. The public health infrastructure and the people who serve in public health departments are also a unrecognized frontline worker class that we need to support. And so thank you for that, and for all of your points on barriers. Another thing I think that really arose in your conversations that I think needs to be sort of highlighted is the issue of data. And so we have some good data in some aspects and some really poor data in other aspects. In fact, like only 8 states are reporting some of the data around pediatrics at this point. So we have a really a dearth of information that really hinders our ability to respond to this pandemic. So what should be done to improve the collection and reporting of race, ethnicity data and other data around for kids so that we know who's getting vaccinated and where outreach should be targeted to reach the kids who are not yet vaccinated? Why don't we go in reverse this time? Dr. Fiscus, why don't you start, and then we'll finish with Dr. Boyd.
Sure. Well, one of the things that should be easy, but hasn't been as easy as it ought to be, is to just make race and ethnicity a required field in the federal reporting of COVID-19 vaccines and any vaccine for that matter that goes into a state registry. And if there was a hard stop where you couldn't move past the field when you're trying to enter the vaccines into those registries, that would be very helpful. The problem is that there are only 3 vendors of these state registries, unless a state has a homegrown registry, and they're completely backlogged in trying to keep up with COVID-19 as well. And so what seems like it should be a fairly simple fix is sometimes not as simple as it should be. But mandatory reporting of those fields would be hugely helpful in making sure that we've got that correct data.
Dr. Calarco?
Absolutely, and I would argue for also a greater investment in qualitative data in the sense that interview data like the data that I shared today takes a huge amount of time and effort to collect, but it's often only able to be done on state level scales or local level scales because of the time and trust involved with the families that we've been working with. We've often spent, even just over the course of the pandemic, 6 hours talking to these families, to each family over the course of the pandemic, and getting to know them, understanding their concerns, listening to their stories, and that takes the person power and the time and the financial resources that go into something like that, make it hard to scale up on a national level. And so I would love to see greater investment in being able to collect these data that allow us to better understand decision making and better understand how parents are thinking about things like the vaccine, and be able to do that not just in Indiana, where I'm doing most of my research, but also across the country to really gather a wide range of stories and really understand on an in-depth level how different groups are making sense of the vaccine.
Dr. Boyd.
Yeah, I would only add, perhaps to underscore what Dr. Fiscus said before, which is the data infrastructure is not just kind of a standalone part of our public health workforce, but the fact that we don't have the data infrastructure that we need is really a reflection of our underfunding of public health for decades at this point. That's both underfunding the human workforce it takes to do the work and underfunding actually just the nuts and bolts, like actual mechanics, the technology that it takes. We have public health departments across the country who are functioning with computer systems that are incredibly decrepit and behind. And so if we really want to be a nation that is kind of first in class in how we address public health crises, we need to make sure that health departments have first in class technology and the resources to power that technology with the human expertise of public health experts to actually carry it forward. So I think greater investments in public health around the data infrastructure so that health departments have the tools they need is a really critical part of closing those gaps too.
Fantastic. I know we're coming up on the hour, so I just want to, just last words from you all on, anything that you think we should really, what's the big one thing takeaway that we should take from this, and how to move forward to making sure that our kids are getting vaccinated and as safe as possible. So when we start with you, Dr. Calarco, and then we'll move to Dr. Fiscus, and Dr. Boyd, you'll get the final word.
Sure. I would say that it's important to remember that as much as it's easy for parents and for communities to focus on individual children, that it's okay also for us to kind of push the conversation bigger and ask parents to think beyond their individual children, and to do so in a way that asks kids to play their part in public health and to be part of the larger community, and to think about what role they can play in helping support their family members and their other kids at school and their teachers and other people in their communities. But at the same time, I think that's only possible if we also invest in supporting families, so that when we ask parents to then help their children contribute to that larger collective effort, that parents feel supported in that as well.
Thank you.
Thanks.
Dr. Fiscus?
Yeah, I would, you know, in a time like this, when we are still in the throes of a 100 years pandemic, I would hope that everyone is waking up every day and saying, what can I be doing to help get someone vaccinated? What can I be doing to help get this to end? And, you know, that may mean calling someone and having a conversation, or offering a ride to someone who might not have transportation to get to a vaccine appointment, or posting and amplifying messages on social media that you see from the CDC and the AAP and other trusted sources, so that we can start to drown out some of this mis and disinformation that is flooding the social media channels. And, you know, and also to legislators to be thinking about what are they doing on a daily basis to help end the pandemic in their community, for their constituents, for their states, and for, you know, really for the world at large.
Okay. And Dr. Boyd, you get the final say.
Well, thank you so much for having me. And I've learned so much from being a part of this panel with Dr. Calarco and Dr. Fiscus. I will just say kids are affected by COVID. Whoever you're working with in their congressional office, that needs to be the line that they say to their constituents. Kids are affected by COVID, both directly as COVID cases, hospitalizations, complications like the multi-inflammatory syndrome in children, which has gone up since Delta, and COVID deaths, and indirectly by the death of their caregivers and secondary caregivers, by missing school, by missing out on major social engagements that help kids actually learn and grow and thrive. Kids are enormously affected by COVID. And the number one way for us to limit that effect is vaccination, so that kids aren't exposed to COVID, their caregivers aren't exposed to COVID, and they're protected. That has to be a line that is bipartisan. It has to be a line that comes from every level of government, from the federal to the state to local government, so that parents know that the number one way to protect themselves and their kids is really getting vaccinated. So please carry that line with you as you guys go back to your offices today.
So thank all three of you for an outstanding conversation, and also, really more importantly, for all you do for kids in this country. So I want to, you know, from the bottom of my heart, thank you all for everything you do, and for being here with us today. And also, on behalf of the entire First Focus team, I also want to thank Congresswoman Schreier and Senator Brown for being our sponsors today, and thank each of you who came today to listen to this conversation. And please pass on the words and the efforts to try to really improve the vaccination rates and the health of our nation's children. For those of you who registered and who attended today's briefing, I want to again thank you, but also you'll receive an email of our summary of today's events and the slide decks that were used today. And this will also appear on our website. So if you want to go back and listen to the conversation again, or share with other people who you think want to hear about this issue, please do so. So thank you all for joining us, and have a great afternoon.